Welcome to the Royal College of Emergency Medicine podcast, examining strategies for violence reduction within our communities. We'll be delving into the Home Office supported ISTV national programme, which stands for Information Sharing to Tackle Violence. With me are Professor Jonathan Shepherd, Professor of Oral and Maxillofacial Surgery at Cardiff University. Professor Shepherd developed the Cardiff model for violence prevention to help capture data on violence-related crime. Also with me are Karyn McCluskey, Chief Executive of Community Scotland, and Michael Cheetham, Data Manager for the NHS Violence Reduction Programme in London. Welcome all. Karyn, let's begin with you. How did you get into this area of work?
I was in the police for 22 years, and back in 2003 I was working in Glasgow as part of Strathclyde Police. The United Nations had come out and said that Glasgow was one of the most violent cities in Western Europe and Scotland was the most violent country. We were tasked with doing a homicide prevention, and we set up the first violence reduction unit, taking a public health model. I was interested in knowing where to put our resources, how to intervene and how to prevent it. And I worked closely and in fact talk very warmly of colleagues who worked in emergency medicine, who were very much at the heart of lots of the successes that we had. And we stole proudly from people like Jonathan Shepherd, who's on the call today, in terms of some of the surveillance that we did. We started to put navigators in all the emergency rooms throughout Scotland to intervene when people came in violence. So a long history with it.
Jonathan, tell us about the Cardiff model.
As a maxillofacial surgeon, I've treated thousands altogether of people injured in violence, as the face is the primary target. But during my PhD studies, I discovered that the police only knew about a quarter of violence that resulted in emergency hospital treatment. So I realised from that emergency departments were a unique source of information relevant to preventing violence. And so altered the software in our emergency department in the centre of Cardiff and convened what became Cardiff's Violence Prevention Board. We first met in July 1997. That group continues to meet and remains a prototype for a city violence prevention board, which every city needs. And I chaired that board for 20 years, from 1997 to 2018. And with my research group, we evaluated and collaborating with the Centers for Disease Control in the United States. And we found that if emergency department data about violence, location, weapons and assailants was used for prevention, then you got a over 40% improvement in prevention over and above what could be achieved using just police data, which is obviously incomplete. Over those years, been very much involved with scaling up what's known as the Cardiff model for violence prevention. ISTV is a very unsatisfactory way to describe this because no information sharing in the world is going to prevent violence. It's the use of that data that does this. For the first time in 2008, the UK government took this on as a strategy that was enhanced after the coalition government came to power in 2010. In 2014, the NHS Digital published for the first time the core data and called it Information Sharing to Tackle Violence. And then since then, implementation around the UK has increased, and very delighted that this has also happened internationally. There are 25 cities in the United States who have implemented the Cardiff model now. It's been implemented in 3 states in Australia, in parts of South Africa, in Colombia, in Jamaica, and is endorsed by the World Health Organization. So been very much involved in advising and campaigning for the adoption of this internationally.
Michael, could you tell us a little bit about your background and how you're involved?
I started off as a nurse scientist, as it happens. About 10 years or so, I moved into health analytics. And more recently, I took up the job of supporting the implementation of ISTV in London. There are a couple of reasons that job attracted me. One is there's a very clear mission. And if you get it right, there's a very clear benefit to getting this data flowing through and out to the people who can use it to affect change. And the other problem is it's quite challenging to implement on the scale of a city like London, where you have 28 emergency departments, you have 32 boroughs, City of London, GLA, VRU, lots of different competing organisations. So you've got to treat London as a single entity. And then the scale and the velocity of the data, the speed at which it comes in, means that you need to take different strategies to analyse it quickly and get it out. And some of those are quite satisfying challenges to address.
What can you tell us from your perspective of the scale of the issue?
In London at the moment, we get about 16,000 assaults that are recorded in emergency departments every year. We've got 28 EDs in London. We've got some audit work from TARM that suggests it should be about 1 to 2% of ED attendance. So we're using that as a rule of thumb for what we should expect. So we're a little below what we should expect at the moment. But what we do know that is a very substantial proportion of police reported violence with injury. So we think we've got a realistic sample of who is being injured through violence in London.
TARN stands for the Trauma Audit and Research Network. Karyn, how did those figures sound for you?
We had around 6,000 that came into hospitals as a result of assaults. Now, that's some time ago. We've obviously reduced that by around 71% reduction that we've shown over the years. But actually, I was just listening, the 16,000, and we had 6,000 in Scotland's tiny. I used to work in the Metropolitan Police, so I know London quite well. But it shows you the scale of the challenge, and lots of people coming in with really significant and serious injuries, life-changing. We're at some of the lowest homicide figures since records began, from a really high. We had about, around 22 victims per million population up to about 2008, and we're down to about 10. Assault from sharp objects has gone down, where people are actually hospitalised, is down from about 1,500 down to about 405. So, that's a 71% reduction, but it's so long-term.
Karyn, what does it take to achieve these kinds of results, this kind of reduction?
The discipline and the resilience you've got to have to be able to drive things down. I've been doing it for a very long time, and you need to be in it, to really understand the data. And I'm a practitioner, so I have to go out and intervene with gangs, and I go into courts and I see young men and trying to keep kids in school. And I never meet anybody who's involved who I think, oh, well, there's a surprise. We've known where they're coming from. So trying to get education to keep kids in school, we try to practice a zero exclusion, but we also intervene with those who are affected. So we did lots of gang intervention. We did SERV, which is the Community Initiative to Reduce Violence. We have all the navigators in hospitals. The real skill in this is mobilising all sectors, right the way up from parenting, right the way up to EDs, to do something to try and prevent it.
If I could just chip in, it's really important that we're evidence-based with what we do. Not everything works. In fact, some things actually make things worse, like boot camps, for example, or the Scared Straight initiative, which is supposed to, or designed, or expected to actually scare young people by showing them prisoners in prison, but we know that actually makes things worse. So some of the effective interventions, they include mentorship and the focused deterrent, getting kids on the edge of gangs or in gangs into a court where the police say, we know who you are. You step out of line again and you're going to be in deep trouble. That certainly works. I was privileged to attend a session in Glasgow in the court where that happened years ago. Very hard-hitting from an emotional, psychological point of view. Then targeted policing works. Precision policing, hotspot policing as it's known, where the hotspots which are identified from police data, but also from this ED data. Cardiff model data or ISTV data, if you will. That is obviously a public health approach because it uses health data better to understand where the hotspots are. And then things like family support, that works. But there are now really important sources of reliable information about what works and what doesn't. So, for example, the Youth Endowment Fund's toolkit and the Crime Reduction Toolkit published by the College of Policing, where the What Works Centre for Crime Reduction is based. They're really great sources of information about what works, because it's not just about trying things on the back of an envelope and hoping that they work. Just like for me treating a patient, we wouldn't prescribe a drug that's not known through randomized trials to work. Exactly the same principle applies to violence prevention.
And what data would you like to see emerge?
Well, just to cover the history in London, which is spectacular, actually, that a Lib Dem member of the London Assembly asked Boris Johnson when he was the mayor many years ago now, why don't we do what they do in Cardiff and use data collected in the emergency departments? And that resulted in a big Home Office grant. And as a result of that, at that time, all 29 EDs started collecting and sharing these data. The important thing about the data is to keep it simple. Less is more. So the data include where precisely did the violence take place? You know, what was the name of the club, the pub, the school, the park, the street location? What was the weapon that was used? How many assailants were there? Because more than one is often a signal of gang violence. And then what was the relationship between the injured person and the assailants? And that reveals a lot of domestic violence, violence against school children, for example. So those are the key data items, obviously including when were the date and the time of the violence. And it's not more than that.
And Michael, so in terms of making sure that the data is more streamlined, what are your thoughts on that?
The way hospitals collect this data is that when somebody comes in, they have these various forms. Maybe there's an injury form, maybe there's a violence form, and there'll be a few fields which will be the fields we've just outlined, the where, the when, and the how of the violence. That makes a really good package to analyse, to distribute for the ISTV purpose, which can be used by safety programmes for community safety partnerships for this violence reduction purpose. You get a free bonus though, because we've collected people related to their NHS numbers so that you can understand the populations that are coming in to you. The ICBs, integrated care boards, have a duty under the serious violence duty to do health needs assessments across their populations and understand the large scale patterns in violence. The actual collection on violence is very focused. It's very streamlined, but if you collect it in the right way, you can widen it with data that is linked for free essentially and make it into a much larger data set. One of the things in London that's happening at the moment, which relies on this, is evaluation of hospital-based youth workers. So if we have these victims of violence properly identified in the ED records, we can then do that evaluation of hospital-based youth workers in London more effectively.
But we are seeing that some of these initiatives are being cut. The initiatives that lead to mentorship, to identifying people in need when they arrive in the ED and they get put into sort of a process that brings them under the attention of organisations like the St Giles Trust or other mentorship. Karyn, you're nodding your head.
Yeah, I mean, we have the same problem in Scotland. I'm a trustee of Medics Against Violence alongside some maxillofacial surgeons. We obviously run the navigators in each EDs. Every single year it's a challenge. We have been incredibly supported by lots of the NHS locations around the country who've used sometimes bequeathments, etc. to fund this. But it's quite unsustainable, and for some really skilled mentors who are in these departments, who are intervening when you've got people who've often been stabbed or been assaulted, and sometimes they're plotting on their phones for tit-for-tat violence, so you're trying to interrupt. But they have jobs and they've got bills and mortgages, and having year-to-year funding is incredibly unsettling for them. So sometimes you're having to give them notice in January that their jobs might go, and of course they're going to go someplace else. It's a real challenge to look at that sort of preventative side and to make good arguments to government. It will be incredibly difficult if that happens going forward. I really worry about it. Progress isn't always in a straight line, is it? We've done really well. It's been consistent. Everybody's kept the pressure on, but it could also go backwards.
If you don't record these people coming in, even when they walk through the door and recorded in the system, then they're invisible to the rest of the system. The people who evaluate business cases, the people who unlock funding for all of these things. So the point is to make visible to the system so that they cannot be ignored.
We know from the cost-benefit analysis that has been done and reiterated in the Home Office's 2019 impact assessment, signed by the Home Secretary, Sajid Javid, then estimated that if just 5% of local authority areas implemented the Cardiff model, which is based on ISTV data, the savings over 10 years would be £858 million. So it's a very substantial amount. And that, of course, reflects the fact that violence has costs, not just in health services like emergency departments, but for policing, for probation, for prisons, let alone the costs for individual people who are injured and find it difficult to get work as a result of their scarring. In some ways, we've been a victim of our own success because there's no doubt that violence has declined, both according to the crime surveys and from ED data, by around 60% since 2000. So the numbers of people coming to emergency departments in England and Wales has fallen from over 400,000 to around 147,000 last year. It's as the Prime Minister has said with the argument for increasing defence spending. It's about the safety of the people. The safety of the people from a threat from overseas is little different from the threats inside the country. Like Cicero said those many, many centuries ago, the safety of the people is the highest law, and that applies at home in the UK just as much as it does from overseas threats.
The horrendous stories that we see reported on the news of children being the victims of serious violence can really make you concerned about the scale and frequency of these events. Is it just because we're seeing more of it being reported in that age group, or is it that the numbers in that demographic are going up?
It's got to be right that every one of those horrific attacks is a good reason to continue to invest and invest better in violence prevention. They're all tragic, they're all preventable. Every one of those should be a prompt to do better and to do more, not to do less, not to disinvest. It's interesting. The press just love reports that violence has increased, and they translate every tragic incident as evidence that this is getting worse, which it often is not. And just recently, the Press Association published information which looked as if the proportion of children which were being injured was going up, but actually it reflected a decrease amongst young adults. And that's where the greatest numbers are, in young adults, people injured in violence and indeed offending violently. So if that goes down, then the proportion of children goes up.
We don't have anybody under 18 in prison now at all in Scotland. So we have fundamentally changed the trajectory for young people by doing that long-term preventative bit, often driven by the evidence, focusing on certain groups. All that work that we did all that time ago on injury surveillance about who was most at risk, about giving visibility to groups and to young people and others who don't always get public sympathy, because it's really easy to demonise young people. I quite like the fact that we make a big deal of them in the press because their lives matter, and they should matter to all of us. They're our citizens, they're our children, and we've just had a murder of a young person, and it's shocking because we don't really have that anymore. The majority of people that we see now as a result of violence are in their 30s. So that dynamic and that picture has completely changed. For me, that's because we've failed to prevent. These are people who we didn't do early intervention with, we didn't keep them in school, we didn't do all the evidence-based programmes, and they're now in the justice system. And I'm in courts all the time. I was in court yesterday. So that has changed. I think for us it shows the benefit of long-term prevention. The fact that we've got no young people in prison, I think, is pretty extraordinary. And the number of 18 to 20-year-olds has also dipped. Is that not public health in its best state?
It will be interesting to see what the figures will be like 10, 20 years from now when the people that you're supporting now hit their 30s.
So if we've already got fewer people coming into the system, and I know that because I am head of community justice in Scotland, so I look at this sort of stuff all the time. And of course, we like to think that those who offend and those who are victims are sometimes different groups. And if we keep the pressure on and are unrelenting in our pursuit of violence reduction, then we will achieve greater changes, in the next 10 to 15 years.
Totally agree with what Karyn said, and that the changes in the justice system, as she described, are very welcome. The reflex attitude often by the public is to lock people up and certainly not to be sympathetic with their plight, especially when they get injured and harmed in various ways.
In London, we also see about 2/3 of people coming into hospital having been assaulted are over the age of 25. Our in-hospital services are largely targeted at the under 25s, and this is something coming out of the health needs assessments that I've mentioned. So I think there's something interesting about thinking about services we're providing to do that violence reduction. ISTV is obviously a part of that, how we support those older people coming through.
There are opinions, perspectives, data being brought forward about younger people feeling that they actually have to carry weapons to feel safe.
Speaking to a young man in court yesterday and, being in care most of his life, living in difficult homeless accommodation, and he's terrified. He barricades his door at night and he says, well, I carry a knife around. But we have to try and unpick the reasons as to why they feel fearful, and Jonathan touched on it slightly. The media need to be a big partner. We try to engage the media to take a reasonable and sober attitude to some of the issues that we're having instead of inflaming people, and so people feel afraid. And young people, they're so sensitive to it. But when I spoke to 350 kids who were 16 to 18-year-olds, and they said to me they pretty much get all their information from TikTok. They're really susceptible to that. So it's a real challenge, and you've always got to be on top of it. And that's why, when I came from a police intelligence background, it's really important to start to listen to stories and to listen to why they're afraid or why they think that weapons carrying is the right thing to do, because we've got the message out about, prison sentences, etc. But if that worked on its own, we'd have no crime.
I agree that it's right that we focus not just on young people, but on young adults, up to at the age of 30, 35. The numbers of people injured in violence and the number of offenders is largely in that age group, 18 to 30, 35. There are examples of interventions that really work, and one of them is connected with alcohol, because alcohol intoxication is a major cause of violence. My research team's been researching this for years, and we found that when the alcohol duty was increased in line with inflation up until the time when George Osborne abolished it in his 2014 budget, then every April, along with the increase in alcohol costs, violence went down. We called it the April effect. It was published in a health economics journal a couple of years ago. I'm convinced, and I think the evidence is convincing, that increasing the price of alcohol in line with inflation or a little above inflation each year really does reduce injury and harm sustained in violence. The other thing that works is brief advice. So people who are intoxicated when they get injured, which is very common, they're not ready to take advice or take account of advice about their drinking when they're in the emergency department. But when they come back to have their stitches out, their x-rays done, their fractured jaw checked on the sober Wednesday after the intoxicated Friday night previously, then they are receptive at that stage to receiving advice about alcohol. And so that can be given in trauma clinic, outpatients clinics. It can be given in probation services. And just one example of how this has been rolled out now, in the armed forces, during routine dental checks, which are compulsory under King's regulations, there is routine alcohol screening and advice given. So all 275,000 armed services personnel went through that in its first year, a few years ago now, and alcohol harm has reduced. That's just one of many interventions that work.
One of the other interventions, Karyn, is where you took doctors into schools.
There's no evidence to show that works. There's never been a controlled trial of that. I wish there had been.
We did it for a whole range of reasons, and it's not a scared straight. I mean, it never has been. We don't do scared straight. It was also to get people interested in health, because I wanted them to aspire to be doctors and dentists and go into nursing. And the kids will ask them questions they would never ask the police. We had one of the Max Fac surgeons go in, and one of the kids said to him, "Where's the safe place to stab somebody, mister?" And he turned it into a biology lesson. And he turned it, like the foot and the arm and the hand, and actually, the kid said at the end of it, well, so there's no place to stab somebody. The consultant, who I know really well, was a bit taken aback. And they were speaking about violence and about the injuries they see and about what they have to do, and just about safety and keeping themselves safe and broader health. And then he thought, no, let's use it as a method to try and teach them and make them think about it. I mean, we've not had many people often that have aspired to get into medical school, and what's it you say, if you can't see it, you can't be it.
Jonathan.
Yeah, this is fascinating, but it is a great example of how these interactions can actually make things worse. Just like scared straight, because, a child that asks where's a safe place to stab somebody, he's getting a lesson in how to stab somebody, isn't he? Without any shadow of doubt. It's one of the examples where we really need a rigorous controlled trial to work out what the benefits are, if there are any. We don't know whether there are benefits or not. That may make things worse. And Karyn will know this, but I've been trying to persuade my colleague in Glasgow to carry it. Come on, do a controlled trial, do a randomised trial. You could easily do that. There are enough schools that just in Glasgow to have control schools and intervention schools where medics in violence go in. We really can't advocate these things unless we've got good evidence, especially at a time of economic difficulty. We really need prioritisation in what we fund and what we don't.
Karyn.
You have to answer kids' questions. That's not a scared straight. That's, a child that's asking or thinks that there's safe places to stab people. I hear it all the time. I'm in jails constantly. I'm in courts, and people say, oh, it's safe because they've often been stabbed. Frequent times they've lived and they think it's all right to do something else. I think, he got to the end of it and thought, oh, well, there's no safe place to stab somebody, which is the end result. You need people to ask questions. I am absolutely a first do no harm. It is not a scared straight. You could get me in to do a scared straight. I could terrify the living daylights, but I know it doesn't make any difference to anybody. It doesn't.
It's an important discussion, this is, Saleyha. But, children and youth who go to prisons with the idea of scaring them, they ask questions of prisoners, exactly the same kind of questions. It might be interesting, but we don't know it's effective.
Michael, what gaps in data are you seeing that we need to urgently plug?
The idea of this very broad linked health data set, which falls out of the administrative data that we collect essentially with no additional effort by frontline staff, is a really useful data set, and that can link across primary care, across mental health trusts, across acute care, across ambulance care, and you get a much richer understanding of the kinds of health needs that you have for the people who are presenting as victims of violence, because these people are coming to hospital not because they want to report something to the police, they're coming because they've been injured in violence. And I think that's important to remember. That's the people we're seeing in health. There is work going on to start to develop some linked data sets, which I think is really important in this context, and look across education and health together, which I think starts to answer some of the questions that we've just had posed. A lot of this background linking and building of data can be really valuable in generating the kind of evidence that we need to support these interventions in resource-constrained times.
Michael, is this a mixed methods approach, considering the breadth of data that exists in this work?
I very much sit on the quantitative side of the fence, but the evaluation work that we're doing around the integrated framework for integrated care in the community in London, for example, does involve a substantial qualitative component. And that's really important because there's a lot of nuance, there's a lot of complicated stories that you can't tell in their entirety through the quantitative data. It's absolutely a part of the work that needs to be done.
Jamaica has really embraced information sharing to tackle violence. What can we learn from them?
The main thing we can probably learn is that this has been funded by the state on a regional basis, so it's systematic implementation across every region, and it's supported by the United States as well. This was basically started by public health professional Elizabeth Ward in Kingston in the University of the West Indies. So the first study that they did was in Kingston, and they compared police data with ED data on violence and found unique major hotspots for violence that just weren't visible from police data, but were from ED data. So one of those was I think it's called the King William Square, which is a transit hub where people get dropped off for shopping or going to school or university. And so that was identified and therefore could be targeted as a result of being identified. And the other one was a community in northwest Kingston. It wasn't identifiable as a community with a lot of violence from the police data, but from the ED data it was. Elizabeth Ward has spoken at the United States Cardiff Network meeting, and it's a real pioneer because Jamaica is not the richest country in the world, and there's a lot of violence that takes place there. Necklacing, putting tyres around people's necks and setting fire to them, it's just brutal and lethal, and they've seen a reduction there. I think once we know that an intervention works, like information sharing and the use of that information, it's about implementing the intervention with fidelity, faithful to its original specification.
What are the bottlenecks to that happening here? Why can't we replicate that and learn from Jamaica?
Traditionally, it's been questioned whether sharing any information collected from patients with any other agency outside health is ethical. But the Information Commissioner and the 1998 Crime and Disorder Act makes it quite clear that information sharing for that purpose, and these data, of course, are all anonymised, so we can put that reservation to bed. I think another one, actually, is that the violence prevention boards who turn the data into practical action, they're made up of professionals who change jobs frequently. So police officers are moving on a regular basis. Local authority officials often move on from job to job quite regularly. So the stability and continuity of those violence prevention groups, that can be an issue. And I think one further one is that the recording of this information in emergency departments is best done by receptionists or triage nurses, but they need to be constantly encouraged by an ED consultant, for example, in every ED, to make sure that the quality of those data remains high, because it can easily slip, especially if no one appears to be using the data. Then the receptionist and the triage nurses, they'll say, well, nobody's asking me for the data, so why should I bother? The management, the leadership in emergency departments for that is important.
Michael, and then I'll go to Karyn.
A really important point about feedback. This is not necessarily data that's useful in an emergency department. It's useful to other people. So the people collecting it have to see that it is being used. And that's one of the things that I think has contributed to our recent success in London, that we've had data quality reports going back to emergency departments so that they can see the effect of what they're doing. And as we embed it back into the CSPs, I hope we'll be coming along with tales of success outside and particular actions outside of the emergency departments.
All of the above and IT. We would get systems started and then IT would change, and of course it would all fall. We were quite lucky that we've had consultants in the emergency rooms who've stayed there for a long time and have driven it. And the relationships absolutely matter. You know, that you're going in, you're telling them, as Michael's just been talking about, the fact that the violence has come down, and they can see it as well. You know, they're seeing, you know, the people in the triage, etc., and it's a different profile. So that's been one of the big parts. But IT, don't get me started in IT and surveillance systems.
We know how to tackle public health challenges in the UK. We've seen what's harmful and then done something about it. Why is this not being invested in the same way? Why have we not flooded the network with ISTV so that everyone knows what it is, from healthcare workers, politicians, policy, and the lay person at home?
At the top of the office, to start with, the Home Secretary can't tell the Secretary of State in the Department of Health what to do. And neither can the Department of Health tell the Home Office and tell policing that they ought to be using these data. So there's a difficulty at the top of the office. I think on the ground, as I say, people move around a lot, you know, so local authority, it's you know, we're not all like, I mean, Karyn's been in the same job for ages and so quite a long time, and Michael has too, and I've not changed jobs that often, but people do move on. And so I think the lack of continuity, say in middle management in policing or local government, means that the people change a lot. And so they've got to be re-educated, reinvigorated to do that joined up type work. Now, just as an example, I remember we wanted to make sure that there was a free text field in the software so that in emergency departments, the name of the pub, club, street location, park, school could be recorded. It took a meeting with the then Prime Minister at Theresa May's summit on knife violence to actually make sure that that happened, because it was only at that level, Prime Minister, Cabinet Office, I guess First Minister in Scotland, to actually make things happen across sectors. The other reason, I think, is that health hasn't really taken this on, certainly not in England. Now, in the United States, the Centers for Disease Control, which is a federal public health agency, has taken this on. But Public Health England haven't taken this on. It's left to the Home Office to deal with what we've all said is a public health issue. So I think that leadership in health at the top of the office is important. And unfortunately, Sajid Javid, when he moved from Home Secretary to the Department of Health and Social Care, he forgot that he signed that impact assessment. And if he'd remembered, it might have produced some top of the office leadership on violence prevention in health.
I keep comparing the public health national approach to smoking. Okay, this is violence, but it's behaviour that impact the health and well-being of individuals. Why is it that this particular issue has not gained that amount of interest at that level? I see you're nodding your head, Jonathan.
So far, there's been no legislation which mandates city-level violence prevention boards, multi-agency. And you don't need they need to be lean, they need to be manageable, with police, health, local government, education, executives sitting around the table, looking at the data and deciding what interventions to introduce and implement. But we don't have violence prevention boards. We've got community safety partnerships to do with all kinds of crime, not just violence. And they're statutory, which is a help. We have violence reduction units, but they're regional Well, just under half of police force areas have those, and they're not statutory, and they don't have any statutory responsibilities to tell community safety partnerships what to do, for example. If I was sitting in the Home Secretary's chair, I would take steps to legislate to make sure we have a violence prevention board in every city. The metropolitan areas like London and Manchester and Birmingham are slightly different, but certainly every city needs that, and the metropolitan areas need a similar kind of approach to make sure that violence prevention is prioritised on a multi-agency basis, as you've rightly pointed out.
This has been an initiative that has started by a clinician, by yourself, Jonathan, and again, in Jamaica, you spoke about a public health clinician who then also took the baton and ran with it. We're doing our part. Other players are not. If there was a different demographic within the UK that was affected, possibly those that are not from deprived areas or who don't come from a background of poverty, would we have a different approach? Is it because of the demographic that we are not having the money, the effort, the concerted push to get this across the line? Karen, you've put your hand up.
I was listening to Stig Abel on Times Radio, and it was about the prison population, and he had a number of politicians on 3 days in a row, and on the first day he said, "Do you think anybody really cares?" And I thought, that's a great question. Nobody answered it. You really have to genuinely care. These are people that sometimes that you'll never meet, you'll never come across, and quite easy to shut your curtains in an affluent area where you're not going to come into contact with it. You might come into domestic violence, etc., but the type of interpersonal violence that we're talking about, to make people feel compassionate and empathetic about people they may not meet, I think is probably one of the biggest challenges that we have. I mean, and I'm in it every single day, and I'm dealing with people who are in the worst types of challenge. Their lives are really poor. They've not got a life that's predictable, understandable or manageable. They have no hope. And people are so isolated now, and we're in such a populist society, and it's so weaponised, the whole agenda is so weaponised, that it's incredibly easy to other a whole group of young black men or young Asian men or young white men in Glasgow who you can demonise. And I still think it's one of the biggest challenges that we have, is to make people feel passionate and to care about it, because these are our children, it's our society, it's our communities. It's a constant uphill battle.
Is it the job of leadership to care about it? Because it's leadership that can make the change.
I think you're right. I think we have to care about it. I mean, I'm quite proud of being a public servant. I really care about it. I care as much now as I did when I started in the early 2000s. So we do absolutely need to care. Politicians need to care about it. And so it does have to come from the top down, but also from communities upwards, amplifying the voices in communities saying, we don't want this for our young people or our older people, we don't want it for our communities. And it's incredibly important to feel safe where you live. If you were looking at Maslow's hierarchy of need, and when they talk about the need for a home, to feel safe. So yeah, I think we need to keep shouting and maybe get on TikTok. Saleyha, I'll leave that for you.
Jonathan, I know that's quite a big statement. My belief, until someone proves otherwise, is that it's the demographic that's affected. Hence, top tier leadership is not getting behind this in the way that it needs to.
I think that equality, diversity and inclusion applies very much to this. I chair the Youth Endowment Fund's Grants and Evaluation Committee, and it's really, really important to us. And this can take all kinds of forms. In Wales, better not mention the place, but the people who are discriminated against and sometimes targeted are white English people. And so this can take different forms, and minorities of all kinds can be victimised and forgotten or ignored or not given the value that they should be. I'm not sure. I think that the reasons this has been not given the attention it should have been are probably more, for me, those other reasons which we mentioned earlier, rather than that. But it's still really important, and it's still a factor. So, yeah, we should certainly make sure that minorities are not ignored.
Now, I want you to imagine that we found ourselves in a place where resources, including funding, are now all readily available. What would be the very first thing you'd do in order to reduce violence? Michael?
I've got 2 things I think that I'd like to do. The first is to mandate clinical systems to collect this stuff and really drive that so that it's easy for staff. They don't have to switch between different forms. They see a person who's been assaulted, they can click a button and there you go, you're done, and you can move on with the rest of what you need to do to treat that person. And I think the other thing would be, I think violence reduction nurses within London have been quite effective where they've been deployed in terms of getting people's minds to think about this, to remember this, and to do things around it. So I think some funding for violence reduction nurses would be excellent.
Jonathan?
I've mentioned one thing, to legislate so that city level violence prevention boards are universal. So am I allowed another one?
Absolutely.
I think comparative data on serious violence is needed. So in the past, and this was stopped in the mid 2010s, we all used to receive in community safety partnerships tables of to show how we were doing in our family of most similar cities, most similar as designated by the Home Office. And they were a real incentive. I remember looking at the data quarter by quarter, and I wanted to know, how's Cardiff doing in comparison with Sheffield or Plymouth or Stoke-on-Trent? And there's a kind of competitive element there because we all want to be in the safest city. So I think reintroducing those, it's called iQuanta, IQUANTA, iQuanta tables would be a great performance indicator for joined up, the partnership working in cities and towns across the UK. So I want to reintroduce those.
Thank you. Karyn?
Yes, it would be fantastic to have all the surveillance in place and for it to be national, so we could have that consistently, because it's not consistent up here. It happens at times and then it drops off and then we have to start it again. But I suppose just more of the money for that preventative, that navigators in hospitals to keep that pressure on, and for that broader preventative aspect. And it's still a big pressure around violence because it's never disappeared from our cultural memory, but also a little bit of a positive spin. The young people I meet are fantastic. They lead good lives. They are so much better than my generation. They drink less, even though we've brought in minimum unit pricing up here, which has been incredibly contentious. They drink less, they take less drugs, but that's not to say that all young people have lives that are great and they don't end up, getting drawn into stuff. So just that more focus on that sort of prevention. And if it matters to us, it needs to matter when the budgets are set. And at the moment, that doesn't always seem to be the case.
And if I'm allowed to say, I would go back and look at all the other public health, massive national campaigns that we've run and had huge successes. Things that we never thought would happen as a society, but now are in place. What instruments were brought in to make that happen? Television campaigns, radio campaigns, big publicity, leaflets through the door. What can we borrow from there to help push this one across? That would be mine. Thank you all for your time. Karyn McCluskey, Professor Jonathan Shepherd, Michael Cheetham, and thank you to everyone who's been listening.